will try to not use too much of a Baltimorean accent so that we don't need a translation from Baltimorese. I appreciate the invitation. I am involved in this area in part because I run a clinic on seeing patients with chronic fatigue syndrome. And about 20 years ago, we noticed that almost all of the adolescents had some form of orthostatic intolerance, either postural tachycardia syndrome or syncope, or neurally mediated hypotension, as we called it. And along the way, we noticed that many of these patients were quite hypermobile. We first reported a group with Ehlers-Danlos syndrome, and then identified that joint hypermobility was present in 60% of our CFS adolescents. So much higher than the usual reported prevalence. As this audience knows, orthostatic intolerance syndromes have been reported as presenting features of a variety of neuroanatomic problems, including Chiari malformation. And so it's not surprising that we started seeing a number of patients with anatomic abnormalities as part of this mix. For those who haven't spent a lot of time looking at these circulatory dysfunctions, the two common forms of orthostatic intolerance that we see both in pediatric and in adult chronic fatigue syndrome, as well as in Ehlers-Danlos syndrome, are postural tachycardia syndrome and neurally mediated hypertension. Many of us learned of that as vasovagal syncope, but not all of these patients are syncopal, so we prefer the other term. What you can see on the left is that with either standing or tilt testing, this is the person in the black is the heart rate. Here is the individual adopting the standing posture. Heart rate goes up about 50 beats per minute and continues. And then as soon as the standing test is stopped, after 10 minutes, the heart rate drops back down. This is characteristic for postural tachycardia syndrome, or POTS. We require a 30-beat change in heart rate between supine and standing for adults, 40-beat change for adolescents. And we expect that there's a reproduction of the typical symptoms of lightheadedness, headache, visual blurring, some of which you heard about as features of these cervical problems. On the right is a medical student who had Ehlers-Danlos syndrome. Notice that when she stood up, her heart rate in black went up very little. And at the 6-minute point, after becoming immediately lightheaded and pale, she had a drop in heart rate with a plunge in blood pressure and some tonic-clonic movements. And she was managed quite successfully with medication. I wanted to present a couple of the patients that Dr. Henderson and I have collaborated on as a way of discussing this further. One showed a marked dissonance between the initial presenting features and her neuroanatomy. This was actually before I met Dr. Henderson, but I think she illustrates some of the points. This girl had been healthy and quite active until the onset of mononucleosis at age 12. She had a little bit of improvement in her energy level, but never got back to her pre-mono level of function. By 15, she had become more fatigued and was tired all the time, worse with any exertional activity, including something that will be relevant to this audience, playing any wind instruments. She reported lightheadedness on a daily basis, especially with heat stress such as showers or if she was standing in the choir. And in addition, she had a number of features like unrefreshing sleep, post-exertional worsening of her malaise for 1 or 2 days after an activity, trouble with pain in the joints, and newer difficulty with cognitive aspects. She would have a headache maybe every 2 days, and I want you to keep that in mind for when you see the picture of her MRI. On her examination, we noticed that she had soft, velvety skin, a high-arched palate, hyperextensible skin in the triceps and the upper eyelid, loose sclera, a high Biden score indicating hypermobility. And at that time, at least on my hands, her neurologic examination was normal. This is the slide showing her response to standing, indicating a 55-beat change in her heart rate within 10 minutes of standing. So she met criteria for POTS. She was symptomatic with fatigue, lightheadedness, nausea, and warmth. And so our diagnostic formulation at the beginning was that she had chronic fatigue syndrome, POTS, and EDS. With some salt and fluid, Florinef and Midodrine, medications we use for the orthostatic disorders, she was able to get to school more regularly until 8 months later, when she had consecutive viral respiratory illnesses, nothing, no trauma, but got markedly increased fatigue. Her sleep was more disrupted. She started describing frontal and retroorbital headaches, and by this point was unable to attend school. I had her come back to Baltimore, and on return to clinic, her exam was entirely different. She had rotatory nystagmus, a diminished gag reflex, very brisk reflexes with 2 or 3 beats of clonus at the ankles. All of that had been normal 8 months earlier. And here, I think you'll see quite an extraordinary MRI. I don't think I've seen one worse in my clinical population. She had probably gotten immediately worse because of the development of acute hydrocephalus. I don't want to go into her surgical course, but just to emphasize the initial presentation with fairly mild symptoms of fatigue and lightheadedness. Second patient is one who had delayed recognition of craniocervical abnormalities. And this boy presented at 16. His first sign of circulatory trouble was at 14. When his school was visiting one of the local museums, he fell backwards after fainting, striking his head. His second syncopal episode was after holding his breath using his asthma inhaler. Gradually, he became more symptomatic. By 1 year later, he was fatigued all of the time and would report palpitations, lightheadedness, mental fogginess, but still fairly infrequent headaches. Here's his standing test. He had a mild increase in heart rate, 41 beats per minute between the supine and the upright tilt test. But what you see at 12 minutes is a profound drop in his blood pressure to the point where he was not getting cerebral perfusion. Then he came back at 16 having hurt his neck with a fall in the shower. And following that, he noticed a worsening of his orthostatic symptoms as well as some emesis. After that point, any neck extension posture, looking up at the sky, for example, provoked a shooting pain in the occiput and the neck, which is probably one of the early clues as to what was really going on. Use of a soft cervical collar seemed to help. He used it just for a week or two, and that settled down the exacerbation. And from that point on, for the next 2 years, he did fairly well with medical management, with Florinef, salt and extra salt and fluids, and physical therapy. He was able to attend his high school full-time, engaged in drama productions, and was accepted to one of the Ivy League colleges. When we saw him in clinic at that time, his Beighton score was 2 out of 9, so not meeting the full criteria for hypermobility. His neurologic exam was normal with the exception of the fact that lateral neck extension, or side bend and extension provoked discomfort. So at 18, what changed was that he struck his head horsing around. It was not a major trauma. And in the next couple of months, he became incapacitated. He had marked intolerance of any upright posture. He couldn't stand more than 2 to 5 minutes. He was worse if he was semi-reclined than if sitting. And he would describe the fact that he couldn't support his head. He felt as if his head was being pulled downward. He was uncharacteristically panicky, emotional, and tearful, which led to a number of misadventures with diagnosis and treatment. He reported blurry vision and muffled hearing. And importantly, with any neck flexion, he got facial numbness, head pressure, nausea, neck weakness, paresthesias, and worse cognition. He was seen by an autonomic neurologist who thought his symptoms were consistent with postural tachycardia syndrome, which seems rather unusual. He was seen by 2 other neurologists who felt his exam was normal. There was enough interest in whether he might have a CSF leak that he got intrathecal saline, and that made him feel worse. Interestingly, he had a repeat Beighton score, and either this was a difference in examination techniques or a change in his flexibility, but he was at this point meeting criteria for hypermobility with a Beighton score of 6 out of 9. And here's his first cervical spine MRI showing the clivoaxial angle at 131 degrees below the 137 we just heard about. He had compression of the ventral aspect of the thecal sac on the flexion cervical spine MRI as reported by the radiologist. And so Dr. Henderson performed a occiput to C2 fusion with a suboccipital decompression of 3.5 millimeter Chiari or tonsillar descent. And this is the post-operative film. And so this boy had been pretty symptomatic for a good year and a half. He initially recovered slowly. He was able to start doing things as he got closer to the 8-month point. And then there was a dramatic upturn in his ability to exercise. And within a month of this improvement, he was able to begin college, which he had to defer for a year. Within a semester, he's taken a full course load. His wellness score, which is a unidimensional well-being measurement that goes from 0, meaning dying, to 100, meaning as good as you could imagine feeling. He was 20 out of 100 pre-op, up to 70 post-op. And I had not actually seen him for 3 years because he was doing so well. He came back recently and told me that he can walk without any limitations around campus. He still has some residual fatigue and lightheadedness and a sense of neck fullness. He has arm weakness and paresthesias with his arms extended to type, suggestive of thoracic outlet syndrome, which one of the Hopkins vascular surgeons has diagnosed him with as a comorbid disorder. And he still has a sense of neck disorientation when he flexes his neck, so he avoids that. But this represents a dramatic improvement in his overall function from preoperative. The final patient I want to present has a similar sort of story. He had delayed recognition of craniocervical instability after a Chiari decompression. This is an 11-year-old who had had some eczema and a number of important food allergies, but otherwise was doing well until the age of 11 when he developed an occipital headache, balance problems, and while he was initially thought to have a sinus infection, eventually he was investigated with a brain MRI which showed a Chiari malformation. And 7 months after the onset of symptoms, he had a decompression. The cerebellar tonsils were at the level of C2 at the time of the surgery. He initially had a resolution, as one might expect, of the occipital headache, and then 6 weeks later, 6 weeks after surgery, the fatigue began, and 2 months after the operation, his fatigue was worse, and he was reporting lightheadedness on a daily basis. The CSF flow study was normal, and he was not thought to have cerebellotosis. He had POTS noted on his standing test, but his overall daily function was quite poor, with a wellness score of 25 out of 100. He could no longer attend school. He wasn't able to work with tutors. He was a bright child who had difficulty reading and retaining information, and became intensely frustrated by his inability to express his thoughts. What the family called emotional meltdowns became quite common. He was diagnosed by the psychiatric staff with atypical depression. Anxiety and panic symptoms began to emerge, and he would be quite mute and tearful in the physician offices. This led to the most feeling that these complications were entirely behavioral, and the pediatric psychiatrists found a paper on cerebellar mutism syndrome, thinking he might have this. The neurosurgeon who had done his original procedure didn't feel there were any abnormalities. When I saw him, he was quite uncomfortable, minimally communicative. His head was resting on his mother's chair, and he would defer to her to provide any answers to the questions. He was quite tearful, had a very hypotonic ragdoll gait. He would walk the wrong way down the hall, bumping into the walls. Had a lot of tension when you examined his posterior neck muscles and the sternocleidomastoids. Deep tendon reflexes were 3+ and symmetrical. He had a resting tremor. He did meet criteria for POTS with a 51 beat change in his heart rate from sitting to standing. We got very little progress in his case with physical therapy and medications directed at the orthostatic intolerance, and he was really continuing to function very poorly. Cervical spine x-rays showed a slight anterolisthesis of C2 on C3 with neck flexion, and the MRI, which I'll show you in a second, had evidence of basilar invagination and a clivoaxial angle of 122 degrees, shown here. This patient was sent to Dr. Henderson for consultation. He then referred the child to Dr. Sandhu, who's here today. And one of the things that helped make the case was with flexion and extension MRIs, he had ventral compression. Post-operatively, he had reduction of the clivoaxial angle, stabilization and fusion of the occiput to C2, and I saw him last month, and this was a different child. All of his symptoms were improving. He was talking throughout. His mother didn't answer any of the questions in clinic. His thoughts were clear. He was expressive. He had a big reduction in panic attacks. Lightheadedness was improved. Headaches, which had been daily, were now 1 or 2 a week, and the tremor was clearly improving. This is just at the 3-month post-operative point. His fatigue was present, but keep in mind he'd been quite deconditioned and housebound for about 3 years, so we don't expect that to return to normal immediately. These are just some of the people who supported our clinical work, and I'll stop there.
Thank you very much, Dr. Rowe, for this fine presentation. The questions for Dr. Rowe. Yes, Harold?
That was one of the most intriguing talks I've heard in a decade, and I want to thank you for it. You didn't want to talk about the surgical result of the first patient, but the story that you're telling is of the fact that these patients get better after this. There's probably nothing in the world that's more controversial or more likely to get screams and yells from pediatric neurosurgeons than that. Did the patient have a change in his or her clinical thing after the fusion?
The final patient?
No, the first one.
Oh, the first one. She first had a decompression. Then could not get up out of bed without vomiting. We recognized that she had acute hydrocephalus. She had a shunt put in, then got up to about a 70% level of function. That drifted down. She needed a cranioplasty, and during that procedure had vocal cord paralysis. So her clivoaxial angle still is unrepaired. She does a little bit of walking around outside of the house now. I would estimate her overall wellness is about 40 to 50. It had reached 70, but I think part of the problem with that girl is she was so fearful of another post-operative problem that she has not been willing to undertake the more definitive repair.
Now I'm sorry, this is really fascinating. The chronic fatigue that you're talking about, is the chronic fatigue part of the fibromyalgia chronic fatigue syndrome panoply, or is it a problem related specifically to things that you could document on a sleep study?
Most of these patients do not have abnormal sleep studies. They don't have obstructive sleep apnea. They might come back with a report of inefficient sleep. I don't want to suggest that there's a very high proportion of people with Chiari malformation among those with chronic fatigue syndrome. We just look very carefully for it now after these experiences, and look carefully for evidence of the cervicomedullary or the craniocervical instability, especially because of the higher prevalence of hypermobility and EDS in this population.
More questions, Dr. Kula?
When post-operatively the POTS improved considerably, and did that correlate with the improvement in chronic fatigue? My understanding, talking to you many times in the past, was that the orthostatic intolerance was really a metaphor for the chronic fatigue.
We can see both. I had another patient whose case I'll include in the chapter for this, who had a very good decompression for her Chiari malformation, but was still fatigued and lightheaded, and she needed medical management of that process. I think it can go both ways, but often if the cervicomedullary compressive problems that we've heard about today are affecting autonomic tone, then the procedure itself should lead to improvement. Doesn't always, and so one has to be aware that that could be a reason for failed medical management.
Dr. Francomano?
Getting back to the sleep issues, here I agree that often the reports are unremarkable, but when we really look deeply at the percentage of time spent in the various stages of sleep, they can often be really remarkably abnormal, with markedly diminished time spent in stage 3 and REM sleep. And I think that probably is contributing in part to some of the sleep issues.
Maybe.
Dr. Benzel?
Yes. How much is pain a component of these children's, young people's total problem?
So in the pediatric patients with chronic fatigue syndrome, we see less overlap than in the adults with fibromyalgia, which is more of this widespread pain syndrome. In the children, they might have a few aches and pains in the joints or the muscles, but that's not the dominant feature. It's usually, the dominant features are usually the complete exhaustion, the worsening of their symptoms after they try to do anything, lightheadedness, and cognitive symptoms. It's as if they suddenly acquire attention deficit.